Okay, good evening, everybody, and welcome to the first of a series of online and face-to-face seminars hosted by the Plastic and Reconstructive team here at Kingsbridge Private Hospital Group. We're really delighted that so many of you could join us. We know it's a busy time of the year, and I should really start by saying festive greetings at this time. The idea of tonight is really to have an informal, relaxed, but yet informative platform for you all to think through some questions, to hear from our esteemed consultants, and at any stage, ask any questions regarding the procedures that either consultant provide and any questions that you have regarding the service as a whole. So I'll take a little bit of an opportunity at the moment just to tell you a little bit of an update, or give you a little bit of an update about Kingsbridge Private Hospital Group. We're now the largest all-Ireland private hospital group with footprints in both jurisdictions. We have over 1,100 staff and over 400 doctors now work within our three main sites. Our three sites are Belfast, Sligo Hospital and Northwest Hospital up at Ballykelly. We have a series of outpatients clinics based at the Maypole Clinic, number 6, number 12 Lisburn Road. We've just opened a new state-of-the-art facility at Kingsbridge Training and Diagnostic Centre at the King's Hall. So I'll take this opportunity as well just to have a few informal introductions. My name is Richard Sweeney. I'm Head of Product and Service Development here at Kingsbridge. I've also got with me Steph Lowry, who is General Manager of the Plastic and Reconstructive team. And Steph will be this point of contact, as well as the booking team within Kingsbridge, for any questions or queries that you have regarding any of the services offered at Kingsbridge. And Steph will put her email up at the end. So without further ado, what I'll do is introduce our two esteemed surgeons this evening. We're very lucky to have Mr. Chris Hill, Consultant Plastic Surgeon. Chris is a member of the General Medical Council Specialist Register for Plastic Surgery, and he serves on the Council of British Association of Plastic and Reconstructive and Aesthetic Surgeons. We've also Mr. Nicholas Hodgins. Nick is a fully accredited plastic surgeon who undertook his medical studies and higher surgical training in a number of prestigious hospitals throughout the UK. And Nick has also completed a specialist training in all aspects of oncological, reconstructive and aesthetic surgery, specialising in the breast. So what we're going to do, I will hand over now to Nick. You can listen to what Nick has to say. There is an opportunity to put your hand up and ask some questions, and we can do that during the talk or at the end. And then we'll have a chat at the end just around communications and how you get further information, and we can answer any questions for you then. Okay? How's everything?
Thanks, Richard. Hello, everyone. Thanks for joining the webinar this evening. So let's get started. Okay, so my name is Nick Hodgins. I'm a consultant plastic surgeon. I've been working in plastic surgery now for over a decade. I'm a substantive NHS consultant with a subspecialist interest in breast reconstruction. And I'm a full member of the British Association of Plastic Surgeons, British Association of Aesthetic Plastic Surgeons, and also the Association of Breast Surgeons. And I completed multi-centre training around the UK, including a number of different centres, which you can see on the slide there: Belfast, Newcastle upon Tyne, Durham, Middlesbrough, York, Manchester, and London. So I'm dual fellowship trained. I'm a specialist in reconstructive and aesthetic breast surgery, having completed a subspecialist period of training at the Nightingale Breast Institute in Manchester, which is one of the largest and most reputable breast units in Europe. I also undertook a further subspecialist period of training dedicated specifically to aesthetic surgery, where I was sponsored by the British Association of Aesthetic Plastic Surgeons. And during that time, I spent a lot of time with a number of leaders in this field around various centres around the UK. And I think I'm probably known in particular for my practice in aesthetic breast procedures and also aesthetic body contouring procedures, which is what I'm going to speak a little bit about tonight, and give you a little overview and flavor for what I offer here at Kingsbridge. So, starting with one of the most common aesthetic breast procedures, breast augmentation. And this is just a little summary slide to give you a feel for that. Procedure time is relatively quick. It's normally about an hour or 2 hours. It's generally conducted under general anesthesia and can be performed as a day case procedure. And the recovery time from this is approximately about a week. So a lot of patients coming asking about breast augmentation are interested to know where the scar placement is. And what's great about this operation is the scar is very discreet and very well hidden in the crease of the breast. It tends to be located centrally and high up in the crease. So it's very difficult to see this on frontal view. Patients often ask also about the length of the scar, and really with modern implant technology and implant delivery systems, which you see on the right-hand side there, that's a picture of something called a Keller funnel, which allows us to deliver implants through incisions approximately 4 centimeters wide. So that really allows us to keep the incisions very small indeed. So there's 3 main types of breast augmentation procedure that I tend to offer. First of all, fat transfer. This tends to give you quite a mild and modest volume enhancement. You do get the benefits of liposuction to a potential troublesome or problematic area or fat store somewhere else in the body. So that does lend itself as an added benefit. But the volume enhancement you get with it is relatively minor, but it does still preserve a natural shape to the breast, and I'll be able to show you some photographs of that in a little second. Probably the most common type of breast augmentation is an implant-based breast augmentation, and this gives you a more significant volume enhancement with improved shapeliness and contour to the breast. And finally, the last type of breast augmentation that I offer is something called a hybrid breast augmentation, which is essentially a combination of implant and fat transfer. And this is really gaining increasing popularity. I've noticed in patient populations, because really you get the benefit of the shape enhancement from an implant, but also the benefits and soft tissue coverage over the implant from fat transfer. And in particular, this is becoming, I find, increasingly popular with athletes who don't want any disturbance to their chest wall muscles, as occasionally we may need to put implants underneath the muscle. And with the advent of hybrid breast augmentation, this can sometimes allow us to place implants on top of the muscle and give increased coverage over the front surface of the implant by supplementing this with fat transfer to the cleavage area. So this is an example of a patient who has had fat transfer only. So this patient had, I think, 2 or 3 rounds of fat transfer. And normally you can transfer, in the region of hundreds of cc's of fat, depending if they have that as a donor site resource, into the breast. And we tend to inject this through very discrete scars, normally located around the periphery of the pigmented part of the nipple called the areola. So the scars are really very well hidden. In addition to that, fat that we transfer into the breast, it can also behave like fat elsewhere in the body. So as per this diagram or this photograph, the patient has gained a little bit of weight, and that's also helped the fat develop inside of the breast. So moving on to implant-based breast augmentation. This is the mainstay of breast augmentation. And this is just a photograph depicting a 355 cc breast augmentation using a round implant. This patient did not have a lot of breast tissue in the upper part of her breast, so we elected to place the implant in something called a dual plane position, which essentially means that the top part of the implant is covered behind the top part of the implant is covered by the pectoralis muscle, your chest wall muscle, and the lower part of the implant is covered by the breast glandular tissue. So this is an example of a hybrid breast augmentation, so an implant and fat. In this patient, we've again placed breast implants. Now, in this setting, similar to the last patient, she did not have a lot of coverage in the upper pole of the breast, which traditionally would lend itself to placing implants into a submuscular position. But this patient actually had implants placed on top of her muscle because she was a very keen athlete and didn't want her pectoralis muscle disturbed. And we've supplemented coverage over the front surface of the implant with fat transfer, and that's mainly delivered. I think you can just see my mouse here. It's mainly delivered to this area, the upper inner aspect of the breast, to give a sort of volume boost to the cleavage on top of what you would just get with an implant alone. So breast reduction is another very common procedure that we offer here at Kingsbridge. This is just a little summary slide depicting the information about that. So it approximately takes about 2 to 3 hours. It's done under general anesthesia. It can be done as a day case, but sometimes we keep patients for one night overnight. I myself do not use drains as part of this procedure. I don't feel that they confer any significant advantage. It can be problematic and uncomfortable for patients, so I prefer to do this procedure without the use of a drain. And the recovery time from this is approximately 2 weeks. So a lot of patients, again, ask about the scar pattern that's associated with a breast reduction. And generally speaking, the commonest type of scar pattern is this anchor-shaped scar. So that involves a scar that goes around the outside of the pigmented part of the nipple, from the nipple down the front of the breast, which you can see just by this diagram, down to the crease, and then a horizontal scar within the crease. Now, these scars do tend to settle very, very well. As you can see on the right-hand side here, you can see the scar that goes around the outside of the areola, and the vertical scar extending from the areola or the pigmented part of the nipple down to the crease, and then the horizontal scar in the crease is essentially invisible as it's covered by the shape of the breast. So breast reduction can really be performed in a number of different ways, and essentially what that comes down to is the tissue that is left behind and the tissue that is taken away. So in very large volume breasts, the majority of the weight and the volume tends to be in the lower and the outer aspect of the breast. So when I do a breast reduction, I tend to preserve a lot of the volume in the cleavage area and take away a lot of the volume in the lower and outer aspect of the breast. So that involves keeping the nipple alive on a blood supply, which comes in from the cleavage area, the upper inner aspect, and then resecting a lot of the excess tissue from the lower outer aspect of the breast where things tend to be very, very heavy. The nipple is then lifted up to a higher location on your chest wall, as you can see in the picture on the right side here. And then everything is closed up with dissolving stitches. And another advantage of taking the weight from the lower outer aspect is it really accentuates the lateral curvature of the breast, which you can see in the post-op picture here, and really improves the overall breast aesthetics. So this is just another example of a breast reduction. This is a smaller volume breast reduction, but you can see that there is a scar when you're on the outside of the nipple, scar from the nipple down to the crease, and the one in the crease is virtually hidden. So breast reduction does give a significant uplift to the overall shape of the breast, as well as reducing the overall volume. Again, some more pictures of before and after breast reductions. These are again small to moderate volume breast reductions, and again depicting the sort of shapeliness and the shape improvement to the breast. And the nipples in a much more perky and higher position on the breast, on the chest wall, sorry, which really emphasizes the sort of more youthful appearance of it. So it really can have quite significant improved psychosocial benefits to having this operation. Okay, so next procedure I'd like to talk about is breast lifts with or without implants. This is a procedure that normally takes about 2 to 3 hours, and it's conducted under general anesthesia with you asleep. It can be performed as a day case operation and occasionally one night overnight. And that's another procedure that performed without the use of any surgical drains. The recovery time from this is approximately 2 weeks. So the scar pattern from breast lifts, generally speaking, can be divided into two main categories. A lollipop scar, which you can see on the right-hand side, which is essentially the scar around the nipple and extending down to the crease, or as discussed previously with breast reduction, the more traditional anchor-shaped scar, which includes the additional scar on the crease of the breast. So a lot of times patients come to see me looking for a breast lift, and they're not 100% sure whether or not they want a volume enhancement as well. And I normally sort of will ask the patient if they're happy with their breast volume and a really well-fitting bra that holds their breast volume in the correct location on their chest wall. And if they are happy with that, generally speaking, an implant is not required. There are additional techniques you can use to redistribute the glandular tissue in the breast in order to improve the shapeliness as well. But whenever patients are volume deficient, such as in the patient on the right-hand side here, then sometimes an implant is used to really restore the shapeliness and the upper pole fullness to the breast. So the patient on the left-hand side here is undergone a reduction mastopexy, so a small volume breast reduction with a lift. You can see that the nipple, instead of pointing down towards the floor, is now pointing slightly in an upward direction, which really emphasizes that youthful and improved breast aesthetic. On the right-hand side, we've performed a procedure called an augmentation mastopexy, which is a simultaneous breast lift with an implant. And as you can see, the nipple has been moved up to a higher location on the patient's chest wall. It's pointing straight ahead over the most projected part of her implant. And she's got a nice upper pole fullness and convexity to the upper half of the breast, as well as some nice lateral curvature to the overall breast shape. Revision breast implant surgery is something I do a lot of. Not not everybody who comes to see me at Kingsbridge will be having their first breast-related surgery. So a lot of patients I see might come to see me with implant-related problems, or perhaps they're not happy with the augmentation that they've had, and they come for a second opinion to see if anything can be done to improve the result. So revision implant surgery is really quite a broad umbrella term, but generally speaking, it can take anywhere between 1 to 3 hours. It's performed with you asleep again under general anesthetic. And it can be performed as a day case, but for the more extensive procedure, it may require a single night overnight. And again, I try to avoid using drains wherever possible. And the recovery time is in between 1 and 2 weeks. There's multiple indications for revision implant surgery, and this is just a small list. It's not an exhaustive list by any means. But sometimes patients might come to see me because they're concerned about the length of time implants have been in place. They may want to change their implant size, and that can be in an upward and a downward direction. They might be suffering from implant-related complications like an implant rupture or visible rippling in the shell of the implant that they can see through the skin. They might suffer from something called a capsular contracture. And to give you an idea of what that is, an implant is not necessarily a natural thing to have inside your body. So your body will always wall it off with a layer of connective tissue called a capsule. And over long periods of time, and in certain other indications, that capsule can activate and contract, and that can really change the shape and appearance of the implant in the chest wall. So that's another reason why patients might come to see me for revision implant surgery. Implants may be not in the correct place. They may be malpositioned. They might sit slightly higher, lower, left, right from where the patient wants them to sit. And sometimes patients, for example, after pregnancy or breastfeeding, might have a complete dissociation in the relationship between where their breast tissue is sitting and where their implant is sitting, and they want to restore that association. and we can look at some photographs of that in a little second. This is an example of a capsular contracture case. This patient has had a previous breast augmentation, but as you can see in the side view here, the implant is really sitting very, very high. This arrow depicts the sort of top limit of the implant, and it's sitting far too high relative to where the breast is. You can again see it here. It's causing a bit of a bubble at the top of the breast. So what we've done here is we've exchanged the implants, and we've removed that tight contracted capsule on the old implant, created a new space for a new implant, and inserted that. And you can see in this photograph and also in the side view that the implant now is sitting lower down in the breast and taking up the slack of the breast skin to give that aesthetic projection. Rippling is another relatively common implant-related complication, and this is essentially little creases in the implant shell, which you can actually see through the surface of the skin. It's a higher risk in patients who have had implants put on top of the muscle and they don't have a lot of breast tissue to be able to disguise the implant, mainly in the upper pole. So this is a patient who has had an implant exchange to a more cohesive silicone gel implant. Some of the older implants that were in use many years ago tended to have a very low cohesivity of the silicone, which increased the propensity of rippling, which you can see in the top photographs here. But the more modern implants tend to use a very cohesive silicone gel. And basically what that means is if we were to take the implant, set it on a table and cut it in half, the silicone on the inside is virtually semi-solid. It doesn't run out of the implant shell. So using a very modern, highly cohesive silicone gel implant can really help with implant rippling. So this is another example of a revision implant surgery. This is a patient who had a very wide cleavage gap, which can sometimes occur if not enough muscle is released, if implants are put in a submuscular position. And what that means is that the inadequate muscle release can drive the implants towards the side, giving the breast a somewhat divergent appearance. But this is something that can be addressed with revision implant surgery, and this patient's had their old implants removed, a significant amount of chest wall muscle release, and new implants put in to bring the implants sitting in a closer position towards the cleavage and improve the overall aesthetic. So this is another example of an implant-related complication. This patient came to see me because on the right breast she had teardrop implants on both breasts, and the teardrop implant on the right side had actually rotated through 90 degrees. She also had an element of tightening of the capsular on the implant. So what we did is she was seeking an increase in implant volume. So we've taken the old implants out, including the right-hand side one, which was rotated through 90 degrees, as well as the capsule surrounding the outside of the implant shell. And we've converted her to a more modern cohesive gel silicone implant in a round shape. So another thing that a lot of patients come to talk to me about is tummy tuck surgery. This is a procedure that, again, we undertake under general anesthetic. It normally takes approximately 2 to 3 hours. Generally speaking, patients would stay for a single night overnight after tummy tuck surgery. I would say that about 85 to 90% of the tummy tucks that I do not use surgical drains. And the reason for that is with more modern surgical techniques, there are ways to reduce the need for a drain with this operation. And that generally involves placing a lot of quilting sutures on the internal aspect of your abdomen, quilting that down to the abdominal wall to prevent any dead space for fluid accumulation. And this has been shown to be a very successful technique in avoiding the use of drains, which can be annoying and problematic for patients sometimes. The recovery time from this is approximately 2 to 3 weeks. So tummy tucks, again, there's lots of different types of tummy tucks that we offer, ranging from a smaller tummy tuck called a mini tummy tuck or a mini abdominoplasty, which is good for patients who have a little bit of excess skin in the lower central aspect of the abdomen, particularly if they've had a previous cesarean section, and that we can simply use the old scar to take away that problematic area. But for the vast majority of patients who have more significant skin and soft tissue excess load on in the abdomen and want an improved lower abdominal shape and contour, we would need to use a what we call a full tummy tuck or a full abdominoplasty, which generally involves a scar which runs from hip to hip, depicted by this red line, and also a scar around the belly button. There is another type of tummy tuck surgery called a fleur-de-lis abdominoplasty, which is also a very good way of improving the abdominal contour, particularly in patients who have had massive weight loss when they have a significant amount of skin and soft tissue excess low down in the abdomen, but also running up the midline in a sort of more vertical vector as well. So it's just an example of some before and afters of tummy tuck surgery. This is a good photograph because you can see the sort of loose skin and the folds of skin in the lower part of the tummy. The mons area, when this happens, tends to sink down a little bit and become a bit drooped. And sometimes with this loose skin, you can get a bit of hooding of the belly button. And you can really see the excess skin and soft tissue in this photograph here, where the patient slightly bent over. And if you fast forward to the post-op pictures here, this patient did not have any drains. I put a lot of internal quilting stitches on the inside of her abdominal wall. The main areas where I put that is in the midline to give that midline depression. And also either side of the six-pack muscles to really accentuate that V cut to the appearance of the abdominal wall, and it really helps to produce a nice athletic-looking abdomen. You can see in this shot that she's got a nice concave abdominal wall with a nice belly button as well, and the side profile as well tells 1,000 words going from this to this nice flat lower abdominal contour. Again, this is another example of a tummy tuck. She had quite a bit more skin and soft tissue excess in the lower abdomen this time. You can see a little bit of an overhang over the waistband. And in the post-op picture, we've trimmed a little bit of tissue off the backside of the abdominal skin flap and placed a lot of quilting stitches on the inside of her tummy, mainly in the midline, but also a couple here and also here to give the appearance of some abdominal dimples and really accentuate the sort of athletic V-cut nature to her abdominal wall. And yes, there is a scar that runs from hip to hip, but this is generally very well hidden in preferred underwear and also in a bikini, for example. Okay, so that's everything that I was going to speak to you about tonight. So if you have any questions, perhaps we'll maybe let Chris do his talk and then take questions at the end if that's the best way to do it. And there's details on the slide there. If you have any interest in booking in to see me, you can call the Kingsbridge booking team, or you can text book to the number there, and a member of the Kingsbridge administration team will call you back. Okay, thank you very much for listening this evening. I'll pass you over to Mr. Chris Hill.
Thanks, Nick. Tonight, I'm not going to repeat everything that Nick has said. I do a lot of the similar procedures, but I'm going to talk about a few other things as well. Mainly blepharoplasty and rhinoplasty. So first of all, who am I? I'm a consultant plastic surgeon. Now, importantly, I'm on the GMC Specialist Register for Plastic Surgery, as are all my plastic surgery colleagues at Kingsbridge. That's important because that indicates that we have undergone rigorous long training in the UK and that training means that we practice safely and that we're experienced, and that should be important to patients. I've been a consultant for 20 years. I have 31 years experience in plastic surgery. And I've worked in private practice for the 20 years and now work exclusively at Kingsbridge. I'm a full member of BAPRAS, which is the British Association of Plastic, Reconstructive and Aesthetic Surgeons. Served in the council for 6 years. Also a member of the Aesthetic Surgery Association. These things are important because these associations have professional standards that we must maintain. And if we don't maintain those, we can be disciplined. Again, that maintains safety for the public. And all of my colleagues in Kingsbridge are members of BAPRAS and practice safely. Well, why choose Kingsbridge? Well, first of all, as I've suggested, the staff, surgical staff, are well trained, and so are the nursing staff. You'll also find if you come to Kingsbridge that the staff are happy. And I think if you have a good experience in Kingsbridge, which many of my patients do, you'll find that part of that is because the staff are happy in their work, staffing levels are excellent, and safety is paramount. I think that's really important in the surgery that we do. A lot of the surgery I do is aesthetic surgery, it's elective, and it has to be safe. There's no need for patients to take any risks, and I will not take a risk for a patient. If I feel that the surgery is unsafe for them, I'll tell them. My patients tell me and give me great feedback about the quality of care in Kingsbridge, and I can see that for myself. That is why I work exclusively now in Kingsbridge. The quality of care, where it is delivered, is excellent, and patients have a good experience. They also have good follow-up. We work together. I've worked with Nick and my other colleagues. If I happen to be on holiday, then one of my colleagues will see a patient if they have a problem. And the staff are always available. I'm always contactable when I am here, and the staff know what they're doing. They've great experience, and they know if a patient has a problem. So just talking about the two procedures now, Nick showed some lovely before and after photographs. It's a little bit more difficult with talking about rhinoplasty and blepharoplasty because I can't really disguise these patients' identity. And Northern Ireland's a very small place, so I'm very reluctant to show you before and after photographs. I have many. I can show you. Any patient wants to see them. If they come to see me, I will try to find a patient with a similar problem that they have to show them what can be achieved. So rhinoplasty can be aesthetic, so it's just about the appearance of the nose, or it can be functional, and that is about how the airway is. So, or it can be both. If a patient's had an injury, they can have airway obstruction and they don't like the deviation shape of their nose. There are some other functional problems that can develop, such as valving in patients who've had previous rhinoplasty where too much cartilage is being removed, and that can also be corrected. Rhinoplasty can be done open, which means that there's a small cut made in between the nostrils here. The scar is very small. And generally, and in fact, generally is indistinguishable. It can also be done closed when the incisions are made up inside the nostril, so there is no visible scar. And that the indications for open or closed depend on what the patient is asking for. If a patient wants a lot of modification of their tip, then I will do it open. But if it's simply a dorsal hump or bump on the bridge, then often a good outcome can be achieved doing this closed. Rhinoplasty is done under general anaesthetic. Surprisingly, it's not actually that painful post-operatively, and patients still don't believe me when I tell them until they come back at outpatients and say, oh, actually, you were right, I didn't even need paracetamol. It can be done as a day case. The risks of the surgery are very low. Now, the thing about rhinoplasty surgery is that swelling and scarring can make a big difference, and a little bit can make a big difference to the appearance. There are limitations. I have no control, as none of us, no surgeon does, over how the patient swells, how much scar tissue they produce, and how long this takes to settle. So there are a lot of patient factors that, as a surgeon, we have no control over. But I make that clear to my patients before carrying out any surgery. Briefly, just to mention what has become an increasingly popular thing in terms of non-surgical rhinoplasty, which effectively is somebody putting filler in your nose. Now, filler can be useful for small contour defects in the nose, but by and large, if you've got a very large nose or you have a large dorsal hump, filler is not going to fix it for you. And it can actually complicate the surgery and make the surgery more difficult. It also doesn't last. So sometimes it is a false economy for patients to have filler when in fact what they need is surgery. I understand that it's sold because it's cheaper than having a surgery, but I think you have to look in the long term because filler generally only lasts about a year. And that means if a patient has had filler, that they're going to have to keep repeating it. And there are risks involved as well. So I'm not a big fan, but it has its place for small contour defects. Then briefly to talk about blepharoplasty, which is rejuvenation of the lids, both upper and lower, or you can do both. It depends on what the patient, what really bothers them. And as I say to patients, there's no point in having something. You should fix what bothers you and not be upsold, or you should fix the thing that annoys you because you're not doing it for anybody else. Upper blepharoplasty can be done under local anesthetic, which makes it fairly quick. The recovery is very quick from an upper blepharoplasty. You get bruising. If you allow, even with the worst bruising, a few weeks will be gone entirely. The risks of complications are very small. Lower lid blepharoplasty is a bit more involved. Often it involves removing or redistributing fat that is pushing forwards against the lower lid. This has to be done under deep sedation or general anesthetic, which is given by an anaesthetist so the patient's airway is protected. The reason for this is the incision is very close to the eyelashes, or in some cases is on the inside of the lid. And for that reason, the patient needs to be unaware. Risk of blepharoplasty, upper risks are very small. With lower, there are some more risks in terms of bleeding and in terms of the scarring and the potential to pull the lid down. But in most cases, a very good outcome can be achieved. In terms of recovery, even with the worst bruising, after 2 weeks, the scars can be covered easily with makeup. The only bit of the scar that really is visible is the bit just in the crow's feet at the corner of the eye, and this in most cases fades very quickly. I do other procedures such as neck outline, including abdominoplasty, which is our bit nice term for tummy tuck. I also do breast reduction surgery, which I don't really view as aesthetic. It's often patients have got so much weight and the upper shoulder and back pain. So it's a really good operation in terms of relieving those symptoms for the patient. I also do breast uplift and breast augmentation. I also do offer fat grafting, which can, as Nick had outlined, he uses for breast reconstruction and augmentation, but it can be used in a wealth of areas for reconstruction or for aesthetics in terms of boosting volume in the face, correcting post-traumatic contour deformities, and I've even used it in a hand for an ulnar nerve palsy where the muscles are wasted. So it's a very useful technique and can get really good results. I also do excisional reconstruction of skin cancers, which we've all done over many years because we've all worked in the NHS, and it is a massive workload within the NHS. I also do gynecomastia surgery, which is men developing breasts, and that is increasingly common due to often weight gain and the use sometimes of anabolic steroids. It can be treated very, very well through a small incision at the nipple. I would emphasize again, the reason to come to Kingsbridge is because I think the patients have a great experience. It is safe. Kingsbridge's governance, in terms of governance, means making sure that things are done safely, is second to none. They are very keen and very careful in making sure patients are treated properly and safely. And I think the patient experience is fantastic. Coming for a consultation does not commit you to have surgery. And if I see a patient who is unsuitable, I will tell the patient. In addition, if I see a patient who would be best treated by one of my colleagues, I will send them to my colleague. And in those cases, I do not charge the patient for the consultation. On most occasions, that is not the case. If you're interested in booking, I would suggest you contact Kingsbridge for a consultation. And coming to investigate does not commit you. No one in Kingsbridge is going to upsell you anything. And I think you will have a fantastic experience in Kingsbridge Healthcare Group. Thank you.
Okay, Chris and Nick, thanks very much for an absolutely superb and informative talk this evening. And we've got a few questions. So I think what we'll do is I'll ask these just general questions to both of you, and you can elect who would prefer to answer them. So this has been asked a couple of times. Is there a good time of year to consider something like breast surgery or tummy tuck surgery? And I suggest probably that the aim of that is to find out recovery time to get back to a sort of full normal life in time for summer.
Yeah, you.
I suppose recovery time is such a broad umbrella term. Really, you have to sort of break that down into the real specifics. I normally tell my patients that driving is out for at least 1 to 2 weeks. I wouldn't want them doing any heavy lifting for a minimum of 6 weeks. That means no gym or strenuous exercise. And I would normally advocate when we hit that 6 week mark, they really sort of ease back into that element of things. So I tell patients to start with walking and light cardio, strenuous cardio before starting to lift weights and things like that. So generally speaking, if you extrapolate that over a further 6 week period, you're not really doing any significant heavy lifting probably until about the 12-week mark. In relation to getting back to work, it really is very job dependent, I think. Obviously, a lot of people work from home now and obviously probably get back to work relatively quickly. But if you are in a very active job or your job does require a lot of heavy lifting, then the recovery time you getting back to work is naturally going to be longer. In terms of is there a good time of year to have the surgery? Really, it just comes down to your own social calendar and your background and really what suits you. I like to try and accommodate patients who come see me here at Kingsbridge as best as I possibly can. At the end of the day, I want to work towards getting you a date that suits your diary and the recovery, etc., suits your diary. So we will work very, very hard to ensure that we can deliver a date that works as best as possible for you.
Okay, thanks, Nick. A question for you, Chris. If you're having a breast augmentation and also consider that you might want a tummy tuck, is it possible to have some of these procedures done at the same time, or would they always be two separate procedures?
Well, this comes down to the surgeon. It also comes down to the patient choice. But personally, I don't like taking any risks for the patient, and doing multiple procedures lengthens the surgical time significantly, and that increases the very small risk which with any long procedure that exists of getting a clot in your leg or DVT, and if that clot precipitates, it can go to your lung and give what's called a pulmonary embolus, which in fact can be fatal. And there are definitely cases worldwide of fatal pulmonary embolus in patients having multiple procedures. Doing 2 procedures actually more than doubles the risk. So personally, I do not do multiple procedures. I know that I have colleagues who do, but I just think that when you've got the choice to do things safely and staged, that I don't encourage patients. And if they want a multiple procedure, I won't be doing it. It also increases the wound size, and by sort of logic, the patient's body has got to expend more energy in healing and defending that wound. So there are lots of reasons why I don't like doing multiple procedures, and I personally think that it is safer if you are wanting more than one procedure to do them in a staged way. I don't think that for a lot of the aesthetic surgery that we do, that taking risks, regardless of how well it fits for the patient, I don't want to ever stand up in a coroner's court and say, well, the patient said it was that it was okay to take risk. It's just not worth the risk, I think.
Okay, thank you, Chris. So this question's aimed to both of you, really. And I suppose there's coming from the back of a lot of plastic surgery being very female orientated, but there is now an increase in male awareness of what's available from a surgical intervention. And Chris, you alluded to gynecomastia. How much time, or how much clinical time, or how much your outpatient's time, I should say, do you attribute to male cosmetic surgery or plastic surgery? And is that something that is really new on the horizon for males?
Yes, in the 20 years that I've been carrying out aesthetic surgery, I have seen an increase in the number of men coming for aesthetic surgery. The two main things that I would, or three things, in fact, that I think I'm seeing an increase in are gynecomastia surgery, because men are talking about it now, and it's more out in the public realm. I had a patient who, and I'm not reaching confidence in this because he went to the press, the BBC, he was on Jeremy Vine's show, and saying, look, guys, if you've got this, it can be fixed, and it can be fixed very successfully. Don't hide. And I've seen men who have been, they've young kids, they can't go to the swimming pool, they don't go on holiday with their kids. It is a real burden, and it can be fixed very effectively. So yes, I think people are less accepting of things. They're just going to hide it. Other procedures that I think I'm seeing more are males or rhinoplasty. And, a lot of that's post-traumatic. Men who've got, played sport, they get hit in the nose, their airway's not good, but actually they don't want their nose to be bent anymore. And blepharoplasty, because upper lids, particularly upper lids, make you look tired. It makes you look older, and it's a relatively straightforward procedure to carry out under local anaesthetic. The recovery is easy, and I think people are realising that and can look a lot fresher from one procedure. So yeah, I think it's going to happen.
Anything else you'd like to add? I mean, I think we're seeing a massive increase in men who are coming to see us about gynecomastia mainly. And I think really the sort of, I suppose, kind of to be a bit more stoic, and that they might not want to come and see somebody to inquire about this. But I think those stereotypes are dying off, and men now come to see somebody seeking plastic surgery is less of a taboo type of scenario. So, I definitely think we've seen a spike in gynecomastia. Most gynecomastias are caused for reasons that are not entirely clear. It's known as idiopathic gynecomastia. As Chris alluded to when he was talking, there are occasional reasons, maybe in terms of medications you're taking, or if you have a hormonal imbalance, for example, that might be causing your gynecomastia. And that's really another thing that we can investigate for you here at Kingsbridge. We have full access to performing blood work and imaging of the chest wall to really delineate the problem and determine maybe what's driving this. So, we really at Kingsbridge take in this sort of holistic element and approach to that kind of condition. And another category of I think, male patients seeking plastic surgery now are the sort of massive weight loss population. I think with the advent of more and more weight loss surgeries being performed, gastric banding or gastric bypass, for example. Not to mention the people who do it through diet and exercise, which is fantastic. And those patients, I think, are coming forward a lot more with problems with excess skin and fatty tissue underneath the skin, leaving folds, causing irritation in the creases. And these are all things that we can address with various body contouring procedures, like are not limited to liposuction, tummy tucks, arm lifts, inner thigh lifts, to name but a few.
I've certainly seen a massive increase in that in the last decade, and because I think, well, first of all, the population that weight gain has become a global problem, and certainly a developing problem in the UK, and then following on from that, people losing weight either through surgery or weight loss, and I think I'd have to say I think that's here to stay, and I think is going to increase. I think the demand for that will increase.
Okay, gentlemen. Andrew, thank you very much.
Thank you.
And just wrap up for the evening here. Thank you.
Okay, everybody. That concludes this evening's seminar. We're grateful to Mr. Nick Hodgins and Mr. Chris Hill for their really in-depth chat this evening. I hope it's informative. I hope everybody's taken something from it. And it's important just to comment on a few things you mentioned, Chris. We do have a very formidable collegiate team of plastic and reconstructive surgeons here at Kingsbridge. We're looking to expand that service very much, and there's a focus on it over the next 12 months. So, conclusions tonight. How do you get in contact? Well, you can contact Kingsbridge Hospital Group on Belfast 667878. You can text book to 66777, and one of the call team will call you back within, if not immediately, within 24 hours. And we've also got expansions now into chatbots. Go to kingsbridgeprivatehospital.com. We have a chatbot which is launching soon, and you can ask as many questions as you wish, and you'll get an informative and intuitive answer to any of the queries you have. And of course, Stephanie Lowry will contact each of you just with her email address and contact details, and you can ask, after you've digested this evening's seminar, you can ask any questions to her directly, and you'll get a private response back. Okay, so thanks very much. That concludes this evening. We'll aim to do another one of these in the next few weeks, and it'll be a different team of surgeons talking about different parts of the body. And again, we'll send out to those that are interested. Okay, good evening, everybody, and thanks very much.